So my name is Rup Tandan, and I am at the University of Vermont in Burlington, Vermont. And I am by training an internist and also a neurologist and also a neuromuscular specialist. So I see, we have a large MBA clinic in our institution, and we see a good number of people with IBM and other muscle and nerve disorders. Out of interest, how many folks here have IBM? Almost everybody. Okay. So today we'll talk about swallowing. So what I'll do is, and I like to just talk freely, and anytime you want to ask me a question, just please ask me a question. It'll be good to address it right there and then. So I'll talk first about the normal mechanisms of swallowing, what structures are involved, and then what might happen in IBM in people such that swallowing may become impaired. So starting from the structure, so the part of the brain that controls the swallowing, the nerves that control the muscles that help to swallow. The part of the brain where these nerve cells live is called the brain stem, so which is the back of the brain here. So you have the two cerebral hemispheres, and then you have the brain stem, which links between the cerebral hemispheres and the spinal cord. Okay? And the muscles that are involved are supplied by cells that live in mainly the lower part of the brainstem. The brainstem has three divisions, top, middle, and bottom. It's called the midbrain, pons, and medulla. And the muscles that control swallowing are predominantly in the medulla, the lower part of the brainstem. The nerves, as they arise from these nerve cells, and then they go and control the muscles that help us swallow, predominantly the fifth, you heard the cranial nerves, which are the nerves that supply the muscles of the head and neck. And then the head and neck is the cranium, hence they call cranial nerves. So there are 12 pairs of cranial nerves, 2 on each side, typically. And the muscles that supply, that help us swallow are supplied by the fifth cranial nerve, which is in the middle part of the brainstem called the pons, and then the 9th, 10th, 11th, and 12th cranial nerves, which are in the lower part. The fifth cranial nerve supplies our jaw muscles, so it helps us chew and prepare the food for swallowing inside the mouth, right? The 9th and 10th cranial nerves supply the muscles of the throat, predominantly. And then the 12th cranial nerve supplies the muscles of the tongue. So the jaw muscles are involved in swallowing. The muscles of the throat are involved in swallowing. And then the muscles of the larynx, which is the voice box, are involved in swallowing. Because as we swallow, there are many other reflex actions take place. We don't talk, and if we talk when we swallow, there's an increased likelihood of choking and aspiration. I'm sure those of you who had barium swallowing done and seen speech pathologists have told you, don't talk while you swallow. And then the other thing that we do reflexly when we swallow is that we don't breathe. So you have to stop breathing for that short moment in time when you swallow. So the 5th cranial nerve, 9th, 10th, 11th, and 12th. The other thing that happens in swallowing is that our breathing has to be synchronized with swallowing. So in people who have problems with swallowing, they may also have some desynchronization between swallowing and breathing. So there are 3 phases. Oh, before I go there. So then, as the food goes into the past the throat, it goes into the esophagus. So the esophagus, or the food pipe, is also a structure involved in swallowing. So there are three phases in swallowing. So you have the oral phase. Oral refers to the oral cavity in your mouth. Then you have the pharyngeal phase, which is the pharynx, which is the structure between the mouth and the esophagus. And then the third is the esophageal phase, which is the phase of swallowing as it involves the esophagus. So the oral phase is and what happens there, and I don't have to tell you this, but chewing is the most important function, and the tongue is the most important organ that helps us move around the food inside the mouth. And there's the muscles of mastication, the jaw muscles, help us convert the food into a pulp. And that is called a bolus of food. So that's the oral phase. And then once a bolus is created, then the tongue lifts the bolus and moves upwards and backwards and pushes it into the pharynx. So the tongue has to be good and strong. And there are many instances of people, and maybe you've noticed that if you have a sore in your tongue or sores in your tongue, you have difficulty in chewing, right? Because the sores are painful, that inhibits tongue movement, and therefore there's difficulty in chewing. Similarly, dentures or other oral thrush in the mouth, or very dry mouth, or medications that produce dryness of mouth can all lead to difficulty in swallowing because of that. Then in the pharyngeal phase, as I said, the tongue pushes the bolus into the pharynx by moving, the back of the tongue moves back and up and pushes it into the pharynx. And what has to happen there also is that there are two protective mechanisms that have to take place. One is that since the top of the pharynx is connected to the nose, the nasopharynx, you don't want the food to go into the nose or liquids to go into the nose. So that opening between the pharynx and the nose has to be blocked. And the way it is blocked is that the uvula and the soft palate, when you look in the mirror, you see that little structure hanging in the middle, the back of your mouth, that's the uvula. And then the two structures on the sides of the uvula that go towards the sides of your throat, they call the pillars of the fauces. So the uvula and the soft palate have to move up and block the food and the liquid from going into the nose. Some of you may have noticed that when you suddenly take a big gulp of liquid or have a big mouthful of food, sometimes the liquid may come out through your nose. And that is because if the uvula is not strong, it cannot block that opening. And then the liquid can run into the nose and come out through the nostrils. So it's a good sign that there is weakness of the uvula in that instance. And the second protective mechanism is that in the back of the throat, so near the voice box, here is the larynx, and the food pipe is behind the larynx. So as the food is going down through the pharynx into the esophagus, or the food pipe, the larynx has to be protected so that the food does not go into and the larynx is the gateway to the trachea and the respiratory passages. And the way that happens is that, so you may have noticed when we swallow, the larynx moves up. If you just put your finger on your larynx and swallow, the larynx moves up. It moves up, and there's a flap of muscle on the top of the larynx called the epiglottis. And the epiglottis closes that opening to the larynx. And then the food slides over it into the esophagus. So all these protective mechanisms, I mean, you know, God must have created, it must have taken him some time or her some time to actually create these mechanisms, because these are so important protective mechanisms. And anything that goes wrong there can lead to, therefore, food or liquids going into the respiratory passages, and that instantly evokes a cough. Anything foreign in the respiratory passages evokes a cough. So if you are drinking or eating, and every time you swallow, you evoke a cough, it means that things are going down the wrong way. They're going into your respiratory passages, right? So one has to take protective action for that. So the food is now in the back of the pharynx, and then the pharyngeal muscles, which are supplied by the 9th and the 10th nerves, we talked about that, they constrict. And when they constrict, they create that propulsive action, and the food then moves down through the constriction of the pharyngeal muscles. So the pharynx is like a funnel. And you can imagine the top of the funnel being pliable, and as some solid material comes into it, it contracts and pushes it down into the esophagus to make sure it goes down the right path, not the wrong path, not back up into the oral cavity, into the mouth. But some of you may have noticed that sometimes food does go back up into the mouth, or you may have to do it voluntarily because of difficulty in pharyngeal action. So I actually haven't used that yet recently. You have to make an announcement.
No, I'm sorry, Dr. Tandan. Somebody wants to ask a question.
Yeah, and I'll take that.
Yeah.
Great.
Thank you. I'm sorry.
That's fine, it's fine. Thank you. Okay. So then when the top of the pharynx contracts, it creates this, the wave of muscle contraction then passes down the esophagus. And the esophagus is a soft tube. The upper third of the esophagus, or the food pipe, is under voluntary control. So we can actually, if there's food that gets stuck there, we can actually regurgitate the food and bring it back up. But then the lower 2/3 of the esophagus, or food pipe, is involuntary, which means we have no control over that. So once the food gets there, it then passes down into the stomach. Where the top of the esophagus meets the pharynx, there is a circular muscle. Some of you may have heard about this muscle, called the cricopharyngeus muscle. So are there any people here who have had a cricopharyngeal myotomy? Yes, so you know. And this muscle is also called the upper esophageal sphincter. So it prevents, it has to relax when the pharynx contracts for the food to be dumped into the esophagus. And if it doesn't relax, there will be difficulty in swallowing, right? And in some people with IBM, this muscle gets thickened and hypertrophied. And when that happens, it narrows that top opening between the pharynx and the esophagus. So there's difficulty for the food in going down into the esophagus. Is that clear? That one? Yeah. So, now what happens in the esophagus? It's a sort of a soft tube, muscular tube. So there is alternating contraction and relaxation of the esophagus. So here's the food in the top part of the esophagus. It then contracts, pushing the food to the bottom part of the esophagus, which relaxes to accept the food. Then this part contracts and the bottom part relaxes. This part contracts and the bottom part relaxes. So this alternating synchronous or coordinated contraction and relaxation of the esophagus is what leads to the food to move down the esophagus. It's a very coordinated function, actually. And quite a few parts of the brain are involved in that, not just the muscles of the esophagus that are involved. So, for example, in people who have Parkinson's disease, they may have an abnormality of this coordinated contraction, relaxation of the esophagus, and they may have difficulty in swallowing as well because of that. Not because they have weak muscles, but it's this uncoordinated action of the esophageal muscles that leads to difficulty in swallowing those. Then the food is down, so it is going down the esophagus, and then it has to get into the stomach. And to get into the stomach, it has to negotiate another sphincter, which sphincter is the name given for simply a circular muscle. That's a gatekeeper. Right? So the sphincter here in the top, the crânopharyngeal muscle, allows the food to go from the pharynx to the esophagus. The sphincter down here, which is called the lower esophageal sphincter, upper and lower, prevents stomach contents from coming up into the esophagus. Because the esophagus is pretty privileged. The stomach is not. The stomach has all sorts of stuff in it, including acid, which the esophagus does not like. So when people have gastroesophageal reflux disease, contents of the stomach go up into the esophagus. The esophagus, being privileged, doesn't like the acid, and the contents are acid predominantly, or food mixed with acid. The esophagus then gets inflamed, and people get what's called esophagitis. So gastroesophageal reflux disease leads to esophagitis, and when there's esophagitis, there is pain in the chest. The esophagus has nerves in it that are painful, they carry pain sensations, and since it is in the front of the chest, it's frequently attributed to heart pain in people. So this is a bit of a side story, but so esophageal pain in people who have GERD can resemble heart pain, including pain in the shoulder and the arm. So then once the food gets past the esophageal sphincter, also called the cardiac sphincter, the lower sphincter, gets into the stomach, and then it is from there on digested. The major nerve that supplies the esophagus, that controls the peristaltic activity, this alternating contraction and relaxation of the esophagus, is the vagus nerve, the 10th cranial nerve. So, do you see how the brain has to be functioning normally? The nerve cells in the brain stem have to be functioning normally. The nerves have to be functioning normally. And the muscles have to be functioning normally for there to be a normal swallow. So any questions about that, about normal or physiological swallowing?
Doctor, if a patient or one of us is having difficulty swallowing, we can do exercises for our outer body. Are there any exercises you can do for your inner body?
Yeah. So I'm going to come to that. I'm going to talk about that. Yeah, and I'm going to address that question as we go along.
Any other questions right now from anyone?
This is my question. I know this is mainly about the not dermatomyositis. But anyway, I had difficulty swallowing last summer from that. Will the information you're giving relates to that too?
It relates to any condition. Yeah, any condition. So it could be a condition of the brain, like stroke, where the muscles of one half of the throat, or maybe even 3/4 of the throat, are affected. It could be due to a condition that affects the brain stem, like tumor in the brain stem, the back of the brain. It could be due to a condition of inflammation in the nerves as they come out of the brain stem and go to the muscles. or it may be due to a condition of the muscles themselves. So any of those, yeah, can produce difficulty in swallowing. Yes, sir?
Perhaps it's on your agenda already. Do you intend to talk about US manometry or pharyngeal Botox or pharyngoesophageal Botox?
Yeah. And I'll talk about, in fact, why don't I do this? Why don't I address these questions now? Because there are so many of them that I'll get confused. So let me address your question first. So what kind of exercises can be done? Unfortunately, not very many exercises for oropharyngeal dysphagia. I think what is important is to be aware that once one understands the mechanism of the dysphagia, whether it be due to dysfunction of the nerves or the muscles or due to some other pathology in the throat, then attend to that mechanism. And as I mentioned that in people with IBM, not only can the throat muscles be affected, but also the upper esophageal muscles can be affected. And in some patients with dermatomyositis as well. It's more common in juvenile dermatomyositis than in adult dermatomyositis dysphagia, but it does happen. And then there are many muscle disorders or muscular dystrophies where dysphagia happens. So once we know what stage of swallowing dysphagia is at, oral, pharyngeal, esophageal, then one can attend to the cause, that particular cause of dysphagia. But yeah, exercising is a two-edged sword. And I know that Dr. Anderson is talking about exercise, and she's talking about exercise here, but one has to be a little careful with exercise in the sense that one doesn't produce significant fatigue of the exercised muscle, because there's evidence that could be deleterious. But exercising is good. In fact, light to moderate exercise is good. Then the question asked here was about Botox. Yeah, Botox is particularly in patients who have pharyngoesophageal dysphagia. Dysphagia between the pharynx and the esophagus. And the most common cause of that is that hypertrophy of the glabropharyngeal muscle. And actually what Botox does, Botox is actually a toxin, botulinum toxin, produced by a bacteria called Clostridium botulinum, which causes botulism. And how many of you heard of botulism? Yeah, so it happens in infants, but can happen in adults as well. It can happen under war conditions where there's wound botulism, and there are other situations too. So the bacteria, and so there are 3 species of Clostridium that produce toxins that can affect nerve to muscle function. And the way that botulinum toxins work is that normally when muscles work, when my muscle is working here, it's my brain telling the muscle what to do. But how does the information get from the brain to the muscle? It goes down the pathway that connects from the brain to the spinal cord in the neck, and then it tells the nerve cell here to activate that muscle. And then the nerve cell fires, and the information goes down the nerve in the synapse, or the junction between the nerve and the muscle, into the muscle, and then the muscle contracts. So it's again a very complicated but coordinated motor act. What botulinum toxins do, and there are about 8 or 9 of those toxins that the most common bacteria produces, is that it blocks the release of information from the nerve to the muscle. So it's a neuromuscular blocker. The way that the nerves talk to the muscles is by releasing a chemical called acetylcholine. And that chemical binds to a receptor in the muscle and causes the muscle to do whatever it has to do. And botulinum toxin prevents the release of acetylcholine from nerve. So the information, even if you will your muscle to move, either it may not move because the information doesn't get to the muscle, or it may move to a much lesser degree. So the motor action is not completely gone, but it is reduced substantially. So you can imagine if you inject botulinum toxin into the cricopharyngeal muscle, the muscle cannot contract or cannot contract fully. So it is in a relaxed state, and it therefore allows for normal pharyngoesophageal swallowing to take place. So that's how that works. And the other second part was manometry. So esophageal manometry. So manometry is simply a fancy name for recording of the pressure, right? And since it's esophageal manometry, it's recording esophageal pressures. So what the gastroenterologists can do, they have this special instrument called the esophageal manometer. Sometimes it can be attached to a scope, actually. And after they anesthetize the oral cavity and the pharynx, they pass that scope down into the esophagus, and they measure this alternating contraction, relaxation of the esophagus, and the pressures that are created in the esophagus by this alternating peristalsis or contraction, relaxation of the esophagus. And if the esophagus doesn't move normally, then they will be able to see in-coordinated action through the scope, and the pressures are going to be very attenuated or reduced if the esophagus doesn't work normally. So that's another way of looking at functional dysphagia. Functional meaning there's nothing structurally wrong with the esophagus, but it's not functioning normal. There is a modified barium swallow that I'm sure some of you have had, and a video swallow, looks at the structure predominantly of the swallowing mechanism, the swallowing pathway. It also looks at function too, but more so structure than function. That's your question?
You didn't address pharyngoesophageal manometry.
Yeah. So yeah, I'm not very familiar with that. Yeah. Esophageal manometry is what I typically send people for, but I'm not very familiar with pharyngoesophageal manometry. You want to tell us about that?
I undergone it
Okay.
prior to Botox.
Okay.
It was actually fatal.
Closer to hear you.
So this is just my personal experience of one. In the speech swallowing clinic of Dr. Carter Wright at Wake Forest in Winston-Salem. And Dr. Wright does Botox more for spasmodic dysphonia, speech problems, but also for swallowing problems, and likes to have manometry done to measure a gradient across the cricopharyngeus. And they feel that it ought to be done without anesthesia, so it's a bit uncomfortable. And in my case, it wasn't possible to even get past the cricopharyngeus, so therefore no gradient was measured. High gradient patients, in his experience, respond better to Botox. He also indicated that, unlike his speech patients who seem to need Botox every 6 months or so, the majority of his swallowing patients never come back for additional treatment. I'm 30 months post-treatment, and I think mine is back. He had led me to believe that that was the minority of patients who have recurred. He said this is an unexplained phenomenon. Why is retreatment not so much required? Interestingly enough, the diagnosis of IBM was never mentioned in my evaluation or treatment, including seeing a neurologist that, unlike most speech swallowing clinics, which are just ENT, there's a neurology partner who's part of the speech swallowing clinic. He also didn't mention IBM.
Okay, thank you. So let me make a few points on that. So one is that, different muscles behave differently to Botox. So the magnitude of the effect and the duration of the effect can be very different between different muscles. I suppose what I gather from what you're telling us is that if you cannot show a significant structural component responsible for the dysphagia, then you can do pharyngoesophageal manometry and look for a difference in pressure. So to surmise that there is functional abnormality in the clavipharyngeus muscle. So if there's a gradient, which means if there's a difference in pressure between the pharynx above the muscle and the esophagus below the muscle, then there's a functional component to preventing the food from going down and producing dysphagia or lipids from going down. And that there may be value in using Botox in those instances. Of course, you couldn't consider a surgical approach for the muscles like in the myotomy because there's nothing to see as such, and there's no hypertrophy or thickness of the muscle as such. So that's what I sort of surmise from that. Yes, ma'am.
Doctor, how prevalent is swallowing difficulties in IBM, and at what stage, and what can the IBM patients do to minimize that, if anything?
Yeah, very good question. So amongst the 3 most common inflammatory disorders of muscle, swallowing difficulty is the most common in IBM. And in different series, up to about 50% of people with IBM can have difficulty in swallowing. In some series, a little lower number, but up to about 50%. So, and it's largely because of pharyngoesophageal dysphagia. So there's no problem with the lower esophagus in those people. It's mainly the muscles of the pharynx are affected, or the clavipharyngeus muscle is affected, that produces dysphagia. I think that what can one do? One is to be aware. So, and the way that one is aware is that number 1, it takes longer time to eat. So, chewing is okay, or chewing may be affected, but it takes a longer time to eat. So if one's eating in a social circumstance or with family, then, everybody else is done and you are still, and that's not unfamiliar. And the other is that when you eat, you find that it takes more effort, or a second swallow or a third swallow to push the food down and back. Or there may be choking. And choking doesn't have to happen with each swallow. It can happen with a third swallow or fourth swallow, or maybe twice a week or so. The fourth thing is that there will be what's called nasal regurgitation of liquids. So liquids come out through the nose, suggesting that there is weakness of the uvula of the palate. Frequently, dysphagia or difficulty in swallowing is associated in people who have muscle disease, is associated with nasal regurgitation, if one asks the question. What can one do? Chew well. Avoid different consistencies of food simultaneously. So, avoid dried foods, so nuts, breads, or bread with softer components of food attached to it. So once you mix different components of food, there's more likelihood of actually problems arising with them. And then I mentioned the small mouthfuls of food, chew well. In some instances, and some of you may have been given this advice after the modified barium swallow, or video swallow, that you are told to tuck your chin tuck. And chin tuck prevents food from going down into the respiratory passages because it sort of tends to close off that opening. Some of you may have been told to actually turn your head to one side or the other, which also protects the food from going down into the respiratory passages. And that one can know which side is good for you. Typically it's the left side. Which side is good for you? When they do a barium swallow, they actually make you look to one side and swallow on the other side. And and see if there is aspiration going on, or turning your head to one side ameliorates the aspiration. So that way you know which side is good. And then, in some instances, take a little liquid with a mouthful of food that you're attempting to swallow. That will be helpful. Make sure you are upright when you are attempting to swallow. And make sure you are concentrating on your swallow. It's so easy, you know, when you don't have difficulty in swallowing, to sit and talk at the dinner table for a long time. You know, eat, drink, talk, almost simultaneously. But when you have difficulty in swallowing, those actions have to be separated. They cannot be combined because they increase the likelihood of choking and aspiration happening. And then, once you are done, then make sure that you are upright for a good couple of hours after you had a meal. Okay, so that's also important. That answers your question? Yeah? Okay. Yes, ma'am.
Microphone.
She had a question before. Sorry, Lois.
I have two questions. One, my doctor asked me what type of foods affect my swallowing. And for me, it's just my saliva all day long. I have to keep pushing to get it back. And I'm wondering if that's a certain muscle group. And then number two, I have polymyositis. What percentage of polymyositis people have swallowing problems?
Yeah, good, very good questions. So let me take question number 2 first, since it's the easier one. It's about maybe 10% or so. So it's not as common as swallowing difficulties are in IBM. The issue of swallowing saliva and having difficulty with saliva is an important one. We all swallow saliva continuously. We don't even know we're doing it. So it's a subconscious and reflex act. So when we see food, we salivate a little and the saliva goes down. You know, if you're sort of tense or anxious, you salivate a little, saliva goes down. So partly from gravity, partly from involuntary or subconscious contraction of the muscles here goes down. But once you have difficulty in swallowing because of the muscles not working normally, that physiological swallowing of saliva becomes magnified because that doesn't happen or happens with much more difficulty. So it appears that, so to some people it appears that, my God, I think I'm making a lot of saliva. Actually, it's not making a lot of saliva in those circumstances. It's that saliva is not removed in the normal amounts. Those people. And it's quite common because, as I said, we are constantly producing saliva to keep our mouth moisture. And if the laryngeal muscles and the pharyngeal muscles are not right, if there's incoordination between pharyngeal muscle contraction and the laryngeal muscles protecting the respiratory pathways, there'll be aspiration. There's likelihood to be aspiration of saliva. So it's not uncommon at all for salivary aspiration to happen. And it's interesting that when salivary aspiration happens, and if it causes a pneumonia, it tends to cause pneumonia on the right side. And it is because of the anatomy of the respiratory passages. So that the right bronchus, the right main bronchus, so here's the larynx, the trachea, the major tube, breathing tube, and then there's right bronchus and left bronchus. The right bronchus is angled differently than the left bronchus. So it's like an eddy current, so that the pathway to the right bronchus is easier for anything that liquid that goes into the larynx into the trachea than the pathway to the left bronchus. It tends to, cause pneumonia on that side. Yes, ma'am.
Does vital stim play any role in myositis treatment for swallowing?
Vital stimulation that the speech therapists do.
Yeah. I don't have any experience with that. Do you want to share that with me, with us?
It's a set of stick-on thing. I can't talk.
Like a TENS unit?
Like a TENS unit.
Electrical stimulation.
Electrical, yes. And it can coordinate
Yes.
the swallowing and it work on certain muscles if they know which ones.
So it's a way of actually preventing this further disuse, loss of function of the muscles. So people use it in the limbs, people use it in the back as well, and people use it they're now using it in the throat muscles as well. So it's a way of maintaining function of those muscles. I don't think it actually improves coordination, but it maintains function of the muscles. Yes, ma'am.
It was my understanding that studies were done that show IVIG helps in dysphagia.
Yeah, good question. I was waiting for that question. So IVIG is intravenous immune globulin. How many of you are aware of that? Okay. So it is actually made from pooled human plasma. So normal people who have their plasma tested for infections, these are plasma donors, and then they remove from this other chemicals and they leave IgG, immunoglobulin G, which is a kind of immunoglobulin that fights infections in the body. So people get it for different conditions, so it's approved for, say, some inflammatory conditions. People get it for lupus or for rheumatoid arthritis or conditions. We use it a lot amongst our neurological practice patients. The first study was done, I think, in 1993, or published in 1993 by Dr. Delatis and his group when he was at the NIH. And it showed in a small number of patients, I think it was about 15 patients or so, that even though IVIG treatment, and this is given as an infusion. So an infusion once a day for 5 days, or now an infusion once a day for 2 days in a higher dose. So it's a certain targeted dose that is given of IVIG as an infusion. And Dr. Delatis's group showed that even though there was no effect on the motor component of the disease, i.e. the strength and functional activities, but that there were some patients whose swallowing benefited, patients with IBM who got IVIG. Unfortunately, that has not been replicated by other people. So IVIG has not really become a standard of treatment in patients with IBM. But I'll tell you that I give, we see and follow about 30 plus patients, between 30 and 40 patients with IBM. And I always offer my patients with newly diagnosed IBM IVIG, because there are some patients who actually they may not benefit from it, but they can be kept stable from it. And I would say about a third of my patients are getting IVIG, maybe once a month, some even once in 6 weeks, and that is enough to keep their condition stable. So in some people who have, say, weakness of the legs, and they are losing the ability to walk freely, and they need some kind of a walking aid, if you give them IVIG, you can keep them walking for a long time. Whereas in general, if you are looking for changes in strength in the muscle, etc., you cannot detect that in people. But functionally, they get better.
You have that hasn't been shown through research. I mean, that's been true for my husband,
Yeah.
that he felt better.
Yeah.
And sometimes research can't measure someone
Right.
saying
And
they
that's-
feel
yeah.
better.
And that's a very important point you bring up, and I think that I would like to see more people doing research with endpoints of a treatment that you guys tell us work and are important. So, walking 20 feet, did that change? The ability to remain walking, did that change? The ability to decrease the number of falls, did that change? And those are important endpoints. Unfortunately, most of the research grants are considered to be scientific grants, and people don't buy those endpoints. I think it's so important to have those kinds of endpoints in research trials. Other questions? Yes, ma'am?
Last summer, when I was having difficulty swallowing, which mine was never severe, I just had to do like concentrate and take longer and all that. I also just about lost my voice, like for maybe 6 months. I was extremely hoarse, and finally, the doctor gave me a high dose of steroids for a month or so, and it worked. And so far, it's pretty much stayed. Every once in a while, I get a hint of hoarseness, but that's it. So I was wondering if that cricopharyngeal muscle, would that be do both those things?
No, it's far away from the larynx, which is the anatomical structure that produces the hoarseness in people. So the cricopharyngeus is at the base of the pharynx, so it's somewhere maybe at the back here, and the larynx is in the front here. So it's that the same muscles, i.e. the laryngeal muscles and the pharyngeal muscles, can be involved in IBM. The laryngeal muscles are not as frequently involved in IBM as are the laryngeal muscles. The myositis may have more laryngeal involvement as such. Yes, that's right. Yes, ma'am.
Yes, I lost my voice too, and it was my speech therapist that says, I think you have myositis. Not my regular doctor, my speech therapist. So yes, I was diagnosed with poly, and now another doctor says I have IBM. So I am learning so much at this seminar that 3 other people said, yes, I have IBM and I have poly also. My biggest question is, I'm at the barium, and even at the barium, when I took a pill, I got stuck. Can you help us at all with tips on how to take pills and get them down?
Yeah.
Putting your shoes out, right?
Yeah.
I'd have to take a handful of pills. And I was always used to throwing my head back thinking that was going to make it go down. And they were always stuck. Somebody finally told me, put your head down when you swallow, and they go right down. I have no problems with it.
Good point. Every patient has to be managed individually. No 2 patients will have the same basis for difficulty in swallowing, even though they may have both, they have IBM. And no 2 patients may have the same resolution of the difficulty in swallowing. So you have to demonstrate as to what is causing that difficulty in swallowing in that particular instance. And then, as you said, that a modified barium swallow is a good test to try and see not only as to what may be reducing the difficulty in swallowing, but also how could you improve it. Because you've got everything on the video screen. And so you are basically looking at the difficulty in swallowing on the video screen. And then when they ask you to do different maneuvers, they can look and see which maneuver actually improves that difficulty in swallowing. And then that's the resolution for that difficulty in swallowing.
Breakfast started 10 minutes ago. If Dr. Tandan is willing to stay and answer more questions, we'll stay, but we've taken a lot of his time. Please fill out your evaluation forms and leave them out at the registration desk if you do decide to leave and go for breakfast. Are you willing to stay for a few more minutes?
I'm fine.
Okay.
I'm at your disposal.
So there's a common condition in the general population, maybe 10% of persons over age 50, of elevation of one hemidiaphragm. Sometimes may not even be clinically important. But is that condition, when connected with oropharyngeal or esophageal dysphagia, is there a connection in your mind?
Yeah. So the question, so you all heard the question. I think the straight answer is no. Because I think that the diaphragm is a muscle of respiration. It's a muscle that helps us breathe. And generally there's enough reserve, because we have two halves of the diaphragm, the bellows as we call it. One on the left side, one on the right side. The diaphragm, so there's this big muscle that separates the chest from the abdominal cavity and helps us breathe. It's a major muscle of inspiration, of helping us breathe in. There's enough reserve in the diaphragm that one diaphragm could be paralyzed, and that's when it is elevated. The paralyzed diaphragm is elevated. Some people are born with that. That there may be no significant impact on breathing at rest. But when those people exercise, or walk up an incline, or walk fast, they may have some difficulty in breathing. Now, there's one caveat to that. Remember I said that the esophagus has to go down and hook up with the stomach? Well, there's this diaphragm in the way. So there is a hole in the diaphragm through which the esophagus goes and hooks up with the stomach. Right? Because it has to go through this big muscle. And if the left half of, and it does that to the left half of the diaphragm. So if the left half of the diaphragm is involved with that condition, there may be some difficulty in swallowing in people. But that's a different mechanism. And that mechanism is not due to difficulty in swallowing because of involvement of the muscles here. It's because of the lower esophageal sphincter that doesn't work normally, doesn't relax normally. So the answer is that generally no, but if the left diaphragm is paralyzed or in some way elevated, it could produce difficulty in swallowing because the connection between the esophagus and the stomach could be constricted or impaired, so not allowing food to go down into the stomach.
Question here. Dr. Tandan, I was tested positive for the IgM antibody, the ND5C1A, and the literature says that I will get swallowing issues faster. Does anyone know what that means?
Yeah, but I'll tell you that there's a paper that came out just recently, a few months ago, 2 months ago, that looked at patients with IBM who had this antibody and patients with IBM who did not have this antibody, and looked at the disease course in those patients. And this was a preliminary study, but it showed that people who have the antibody although they start out with similar levels of involvement, that people who have the antibody may show a slightly faster rate of progression as compared to people who do not have the antibody. It needs to be confirmed, and I think that there's hopefully going to be a study which will confirm that or refute this observation. Yes, ma'am.
What causes a Caxton's ring, or is that congenital?
Yes, it typically is, but in some people, a chronic reflux can produce it too. The Schachter's ring is simply S-C-H-A-T-Z-E. S-C-H-A-T, S-C-H-S-A-I, Schachter's ring. Yeah, oh, sorry about that. Yeah, so it's basically, it's like the cracopharyngeus muscle up there in the throat here, that produces difficulty in swallowing. This ring is down in the esophagus, just above where it joins the stomach. So it's a piece of muscle and lining of the esophagus that becomes hypertrophy and produces a ring-like structure in the lower esophagus. It's a common cause for what we call dysphagia or difficulty in swallowing. It is usually congenital, but can be acquired with chronic reflux in people too. So reflux produces inflammation, and inflammation produces scarring, and that's how it develops in people with chronic reflux disease.
I have a quick question.
Yes.
I'm a caregiver for IBM, and he's recently having difficulty swallowing. He does turn his head to swallow. So what I'm gathering at this point is to keep it simple and be aware and do the different foods simultaneously and drink water, whatever, and just kind of see. I know I'm not looking for improvement, but I'm looking for not as often to have to do that. Would it be my...
Absolutely.
That would be what I'll need to do in this when I'm looking for more trouble.
And also, the other things we talked about, to small mouthfuls of food,
Right.
chew them well, double swallow, stay upright and erect, turn your head if you have to, chase the foods out with liquids if you have to. So all those strategies will be
And you
helpful.
said double swallow?
Yeah,
Oh, okay, I
yeah.
missed that, okay.
Yeah. So I mean, normally when we have a mouthful of food and we swallow it, we simply gulp it down. And we don't have to swallow multiple times to do it.
Right.
But in some people, and people with IBM, because of weakness of pharyngeal muscles, the food tends to pool in the throat muscle. So you may have to double or even triple swallow to be able to get that food to go down. Or if you use liquid, that will help the food go down. Yes, sir.
Hi. Question is back to the topic of IVIG.
Yeah.
You said you recommended using it to patients and 30 patients are using it. Now, when I go back to my doctor, I start the conversation, number one, I want to read something about it to show because I general practitioner doesn't know about these kind of things. So, what would prompt him to send me for that? And the second question is, does insurance cover it?
Yeah, both good questions. So I think that what will prompt him is that number one, is that he needs to be educated about the condition and about the treatments for IBM in particular. And secondly, insurances do cover it. Yeah, I mean, in all my patients that are getting IVIG, there is no problem with insurances covering.
These are IBM patients.
And it may be different with different, because most patients with IBM, I think, are on Medicare, but the local representative of Medicare may be the ones who may be putting their foot down on IVIG treatment. And also, where the people are getting that treatment. Are they getting it in a hospital clinic, or are they getting it in some other clinic, or they're getting it at home? Because all those are possible. And sometimes there are restrictions on where the IVIG is being given to the patient. So you may want to look into that.
I had a quick question. I've been diagnosed with pharyngeal bar, and I've had 2 dilations. I think they're up to 18 French or something like that. At the end of the month, I'm going for a 3rd. I've been trying to get the dilations before I go to myotomy because it's less invasive. Is that the myotomy scares me because they say you have to have a very experienced surgeon to be able to do that. There's a lot of things. Is that the right course? Progression, yes?
And I think that I'm old-fashioned, I tend to be conservative. But if I have a patient who comes to me saying they have significant difficulty in swallowing, and they have a demonstrated cracopharyngeal bar, I would suggest in them cracopharyngeal myopathy. But in general, I tend to be conservative because those maneuvers are temporary. I mean, they are designed to be temporary. They will not be permanent maneuvers. but phenylmyotomy is not also permanent, but is less temporary than dilatation.
Thank you.
Yeah, you